Ramla Tanko. I'm a junior research fellow at the University of Cape Town, and today I'll be facilitating this webinar. Please do introduce yourself in the chat to colleagues using the chat box. So welcome everyone to this inaugural episode of the GIFT webinar series called Women Up to No Good. This is a series where we ask the questions that matter when it comes to female sexual and reproductive health and how research and innovation can improve this. This webinar series is an initiative of the GIFT project currently being led by the University of Cape Town. And we will be hosting this series quite often. I'd like to begin by giving some background to the GIFT project. Just gonna share my screen quickly. Almost there. Can you all see my screen? Okay. So just to give you a bit of a background to the GIFT project, sexually transmitted infection and bacterial vaginosis are highly prevalent in South Africa and cause genital inflammation that has not only been associated with increased HIV risk, but also contributes to adverse reproductive outcomes. And the majority of these infections are asymptomatic, although they are as highly inflammatory as those that are symptomatic. STI and BV are currently only treated when women present clinical signs or symptoms, and asymptomatic infections are often left untreated. Although gold standard amplification tests have been developed to detect these infections, these tests are expensive. They require experienced laboratory staff and specialized equipment. So we have validated biomarkers of vaginal inflammation caused by STI and BV in 5 African cohorts and co-developed the Genital Inflammation Test in Africa. The performance of this low-cost rapid point-of-care test is currently being tested in South Africa, Zimbabwe, and Madagascar. With GIFT, we aim to improve STI and BV case findings, thereby reducing HIV risk in women. We will post a link to the GIFT website in the chat box in case you are interested to learn about the device and the team. So as a GIFT team, we know that clinical solution, whether diagnostic or therapeutic, are only part of the solution for finding ways to reduce HIV risk. If we want to secure health for women across Africa, we need to dismantle structural inequalities that maintain the status quo. And this can only be done through deep reflection and dialogue. So we hope with this webinar series, it will be very transformative, providing space for learning and also for deep thinking about priorities and where impact needs to be achieved. So just for housekeeping, the webinar is going to follow a structured format, beginning with the 3 panelists each giving some input on today's topic. We will then move into an open Q&A session where you are all welcome to ask the speakers questions via the chat box. So please be aware also that this session is being recorded and will be available on the GIFT YouTube channel. And this is also where you can catch up on dialogues that you may have missed. And to ensure that you don't miss out on upcoming dialogues and other important announcements, please sign up for the Gift e-newsletter and also subscribe to the Gift Media channels. These information are currently being posted in the chat box. So for this inaugural webinar episode, we have invited 3 key players in the landscape, and all of whom have experience in the female sexual and reproductive health space, and who we believe can effectively set the foundation for later dialogues. They will each talk from their different standpoints about the importance of ensuring that women are aware of HIV risk, educated about possibilities for staying safe, and enabled to maintain these strategies in the face of their daily lived experiences. So I am going to introduce the speakers. I can just stop sharing my screen. Okay. I am pleased to introduce our panel of experts, Professor Elizabeth Bukusi, if you could please turn your screen on.
So I'm not Elizabeth. I'm Nelly Mugo, and I'll be presenting on her behalf.
Okay,
welcome. But I think because the slides are Professor Bukusi, just introduce her, and then I'll just say who I am very briefly.
All right. So Prof. Elizabeth Bukusi is represented today by Professor Mugo. She is a fellow of the African Academy of Sciences, a senior principal clinical research scientist at the Kenya Medical Research Institute. She is a research professor at the University of Washington, an honorary lecturer at Aga Khan University in Nairobi and Maseno University, and volunteer clinical faculty. She's also a professor at the University of California, San Francisco. In addition to substantial experience in conducting social behavioral and biomedical research and providing HIV care, she has a strong interest in research and clinical ethics and the development of systems and structures for regulation of research. Prof. Mugo, please go ahead and say a few lines about yourself.
Thank you very much. So some commonalities with Professor Bukusi and then some differences. So I am a scientist at the Kenya Medical Research Institute. I'm a clinical trialist. We've done a lot of work similarly across board. And my background, I'm a trained obstetrician gynecologist. I'm not an ethicist like she is. But I've done a lot of work amongst young women and issues of HIV prevention. And both of us participated in the HIV PrEP trials that informed the change of indication for oral Truvada. Thank you.
Thank you, Prof. Mugo. We are pleased to have you join us today. Our next speaker is Dr. Constance Mackworth-Young. She is a medical anthropologist with a research focus on young people, sexual and reproductive health, and adolescent well-being. She is based in Zimbabwe with the Health Research Unit Zimbabwe, where she leads social science research. Welcome today. Our last speaker, but not least, is Professor Sinead Delany-Moretlwe. She's the Director of Research at WITS RHI, Professor of Global Health and Infectious Diseases at the University of WITS in Johannesburg. Her research interests span the intersection between sexual and reproductive health and infectious diseases, particularly in adolescent girls and young women. She's an advisor to the South African National Department of Health PrEP Technical Working Group and serve on several WHO and other advisory committees. Welcome to this webinar, Prof.
Okay, so good afternoon, everyone, or good morning, good evening, wherever you are. My name is Constance Mackworth-Young, and I'm an assistant professor at the London School of Hygiene and Tropical Medicine, based in Zimbabwe at the Health Research Unit Zimbabwe. And I was asked to join this panel to bring in some of my experience from having conducted ethnographic and qualitative research with young people, mostly young women in Zambia and Zimbabwe for over a decade. And in this presentation, I was thinking about HIV risk in the context of women's lives in Southern Africa and the multitude of other risks that they may face. So in conversations about HIV, including for this webinar, we often discuss and ask the question, how do we ensure that women are aware of HIV risk? And in thinking about this webinar and drawing from the in-depth research that I and my team have conducted with women and young people in Zambia and Zimbabwe, I wondered how it would be if the starting point was not that, but rather, how do women view and prioritize their major risks? So to think about this question, I want to start with the story of Rhoda, who's the pseudonym of a young woman with whom I conducted research with for over 4 years. During that time, she was constantly balancing different risks and priorities, as this quote exemplifies. So she said, "College is so important to me. I just know I'll make it and I'll become a nurse one day, and I will be able to support my young brother. I've been managing the fees with the bursary, but now my mum is struggling to pay the fees, and there are extra costs like the ID badge and blankets. I will have to ask my father's cousin, even my auntie. I can really understand why some girls sell their bodies. You've just got to find a way to pay." So here, Rhoda is acutely aware of the risks. The risk of HIV competes with the other risks in her life. She's making rational choices to balance her education, supporting her brother, managing relationships, and the long-term security that she hopes to find through education and getting a job. And this brings me on to the irony of success in terms of HIV. HIV may be the primary concern of many people's work in this webinar, and it is still perceived to be a key public health problem. However, in a large part due to the incredible public health efforts and successes over the last few decades, at an individual and community level, even in highly affected HIV areas, HIV is now often seen as a condition which one can receive a high quality care and treatment for, often in contrast to other conditions where care is either unavailable, substandard, or has a high personal cost. Another example of competing risks that are faced by young women is pregnancy. Pregnancy is a risk that cannot be hidden and can cause big disruption to women's life trajectory. In contrast, despite continued stigma, HIV is often viewed as something that can be hidden and controlled through taking pills. So this quote by a young woman in Zambia said, "I dropped out of school when I got pregnant. All that is over for me now. I can't go back." With a historically singular and successful focus on HIV, it has meant that antiretroviral therapy and increasingly pre-exposure prophylaxis is available and accessible at public health facilities. But family planning to prevent unwanted pregnancies is often inaccessible, either because of unavailability, cost, or social stigma. And this quote really exemplifies the social stigma. So, "Before having my child, I didn't use anything to prevent myself from getting pregnant. Young girls must not take family planning pills if they are not married." And the third aspect that I wanted to touch on in this presentation around competing priorities and risks that women and young people might face is how these competing priorities not only impact decisions that women and young people make in their behaviors and everyday lives, but also if and how they interact with health services. The time and the money required for accessing health services competes with other priorities that individuals have. So, for example, when considering whether to attend a health service, one young woman said, "How long does it take? I must fetch water and carry it home." Male attendance and male uptake of health services has been a continued issue, in part due to their competing economic priorities. So this quote saying, "I would come, but I haven't made any money today. I've got to hustle, and only then can I think about my health." but I just don't think I will have the time. So in amongst the honeycomb that I've sort of pictured of interlinked risks and priorities, HIV is one piece, but it's only one piece, and often due to the irony of success of HIV, it's the one piece that can actually most easily be hidden, treated, and controlled. So given these competing risks and priorities, how can and should we program? To me, a first step is really seeking to understand and legitimize the risks that women themselves experience as priorities, and supporting these as our priorities. And then link what we consider as public health priorities to women's own priorities, having something that appeals to their direct priorities to meet them with their priorities alongside public health priorities. One example where I feel we did this effectively is in Chiedza, an integrated community-based intervention delivered in 12 communities across Zimbabwe over 30 months. Here, an integrated package of sexual and reproductive health services were offered to young people, which included HIV and STI testing and treatment, menstrual hygiene products and care, condoms and family planning, amongst several other services. We found that providing free menstrual hygiene products in a context where they are prohibitively expensive to buy was a real draw for young women to attend. This was a product that most young women wanted and needed, but they were not able to pay to access. So it drew them to Chiedza. And then, while they were there, they would take up other sexual and reproductive health services. So this quote from a young woman who attended Chiedza saying, "I came wanting pads. Pads are so expensive nowadays, and they were giving them for free. And then I also got tested for HIV. And this young woman at that point tested positive." So I want to end on the message of really understanding women's risks and priorities first, and designing programs and services that address those needs, and only then seeing how they can be integrated or aligned with public health priorities. So as such, I think we will end up with more integrated, strengths-based programs that can even link with economic or educational priorities, which meet women and young people at their own priorities. Thank you, and I look forward to answering questions.
Thank you, Constance. Prof. Mugo, are you ready?
Yes, I am. And actually, the presentation I have comes very closely to speaking to the things that we've just listened to from Constance. I think you can see Professor Bokusi's slides. I think
Yes,
you can.
we can.
Yes. So as mentioned, I'm Nelly Mugo, and I'm presenting on behalf of Professor Elizabeth Bokusi. And part of her presentation will talk about the story about what motivates young women. And it really parallels to what Constance has spoken to us about women in South Africa. Then we'll assess the drivers and characteristics of young women that influence their behavior and some of the things around them that increase their challenges, the challenges they have with being aware of risk and ways to raise this awareness. So another real life story. The lady you're looking at is Grace Carey, not her real name. She dropped out of school in Form 2 and was orphaned at the age of 12. She lost her parents due to HIV/AIDS. She has a firstborn child who's 1.5 years old. And then she reported to clinic and she found she was pregnant. She didn't want to carry this pregnancy and was thinking about how to terminate that pregnancy. She's been 3 times to the clinic and tested positive for an STI. Came in with complaints of a vaginal discharge and was treated. And male partner treatment was given. She has shared that she has multiple partners, most of whom are casual, and she doesn't use condoms very often. She has embraced sex work as a main source of income to take care of her young child. And it surprises her each time that she tests HIV negative. She appreciates that PrEP works, and she hopes that there'll be another magic bullet to prevent the other STIs. So she's been a beneficiary of PrEP. But I think the real story is how those perspectives may differ from what we perceive. So then when we look at what are the key characteristics that work with young women and that place them at risk, young women tend to be biased towards the present, what is happening today, the day-to-day concerns. And I think that's what Constance told us in her presentation. I need to hustle. I haven't made any money today. I need to fetch water. That's what we heard. And these can differ by culture and geography, by income, whether you're low or middle income. Some of where we live, the issues are maybe more around food and shelter, companionship, partnership, whether you're married or not. And rarely do young women think about being at risk and whether or not that's a future risk. They also seek novelty and sensationalism. They may seek thrills, and this may come through their interactions with peers. And they're often healthy. It's a time of life where they're physically healthy. And they haven't taken chronic medications, maybe on and off for that discharge or for other issues that arise. They're very socially interconnected. They use a lot of social media platforms with their peers, their sex partners, with families and communities. And these interactions carry a big weight and influence how they make decisions and how they hold opinions. Their opinions are influenced by their communities around them. Social media platforms have connected them to the world, and they're able to adapt this to women and young women through different social platforms. So young women in this region face double trouble. And in Kenya, Botswana, and South Africa, when you look at the left side, you see that up to 60% of new infections are amongst women. And when you look at the right side, you find that STI prevalence for chlamydia across these trials has been between 12 and 29%, which is remarkably high. And though we have a chlamydia epidemic, this may be a lot higher than other populations, coupled by lack of diagnostics, of course, which we heard from the introduction slides, that we lack proper diagnostics that are accessible to the women that we serve. So we say that young women have challenges with issues of risk awareness. How do they perceive their risk? And we find that in the studies we've done where we've scored HIV risk, that girls with high risk scores have low risk perception about their risk of HIV. They're also very biased towards the immediate award rather than long-term gains, and will work towards what's immediate. They, like many young people, have always said this is why young men go to war, feeling vulnerable to danger and disease. It's something that gets somebody else, not them. And then they have to deal with gendered normative contexts and the stigmatization of being at risk. And they're also reluctant, therefore, to self-stigmatize, as it has implications to their social connections and lives. The perception that consequences are no longer dire is also a challenge. From this quote from this young woman, 20-year-old, HIV uninfected. You see, now people with HIV are much better than us. They're taken care of in lots of places. They're the most important people, and the pills for treatment are available. So it's not easy for you to just die like that anymore. I don't know, this is a hard one for me to even read, but she quoted, "I would not have a problem if I get infected." That's something that would have to contextualize to understand how to intervene for that perception. So how do we raise awareness about risk? So I think gain framing for young women rather than risk framing. I think very often we've sold fear. You will get HIV, that's fearful. But rather than protection from HIV, will reward and give you a better life and a future. Peer-led groups create better awareness. Young women work better in groups. Partner and social network involvement, because they work in an environment and community that greatly influences their decision makings and their behavior. And finding ways to promote women's autonomy and equal gender power norms. And that's a challenge. And it's how the behavior is driven, is around her ability to say no and determine and make decisions for herself and stand by them. And we need more women's empowerment programs. to raise awareness. So Professor Bukusi acknowledged Dr. Victor Omolo, myself, Nelly, the RCTP program, and the Kenya Medical Research Institute. Thank you very much.
Thank you, Prof. Mugo. We are going to move to Prof. Sinead now.
Thanks very much for the earlier introduction. And thanks very much to Constance and Nelly for, I think, putting faces or people to what are often kind of the huge, overwhelming numbers that we hear when we talk about HIV risk, particularly in Eastern and Southern Africa. So just, I think, to remind you that each of those stories represents many women who live in Eastern and Southern Africa, and about 2/3 of women living with HIV in our region, 2/3 of people living with HIV in our region are in fact women. And the reasons, I think, for the high prevalence of HIV in women really has to do, as has been beautifully summarized by the previous two speakers, because of a lack of decision-making power about sexual relations, but also contraceptive use and access to healthcare, which really kind of limits people's ability to protect themselves. And in particular, it's clear that adolescent girls and young women between 15 and 24 years old are disproportionately affected. Even as recently as last year, about 5,000 young women in that age group per week were infected with HIV in Eastern and Southern Africa. So this HIV continues to be a threat to health for young women, and it's important that we continue to recognize that HIV is unfinished business. One of the things I think that was truly remarkable was in 2015 when WHO recommended that oral PrEP be included as part of a comprehensive package of HIV prevention. And since then, they've updated their guidelines to include two new modalities, both the dapivirine ring and long-acting injectable cabotegravir. And many of the people on this call, in fact, were instrumental to producing evidence that supported those recommendations. So since then, what we have seen is introduction of PrEP in many programs, particularly on the African continent. And in fact, South Africa in 2023 leads the global PrEP initiations with almost 1 million people initiated on oral PrEP by 2023. And that, in fact, is a remarkable achievement and reflects, I think, people's strong desire to access forms of HIV prevention. But one of the challenges that we've grappled with in HIV prevention programs is really the fact that many people who express huge enthusiasm for taking an oral pill daily actually struggle with that practice in reality. And we have evidence from a systematic review that looked at kind of more than 50 studies in multiple geographies, showing that about 2 out of 5 people will likely stop their PrEP within the first 6 months of starting. And this challenge is probably greater for younger people. And there are a number of reasons why people might stop taking their daily pills. There are individual factors like people perceiving their risk to be low or changed. Many people articulate concerns about side effects, particularly and may have difficulties when starting PrEP. Just taking a pill a day, it's difficult to remember. And sometimes, particularly I think in our setting where young people are moving from home to school to find a new job, often that means that their access might be limited. There are also a range of interpersonal factors that we've observed. So often families are suspicious of why is this person taking these pills? Do they have HIV? And the stigma associated with HIV is still prevalent enough that many people actually don't feel comfortable to take their pills in public. And then for young women, there are the concerns that come with conversations with partners who might think that they are trying to protect themselves from other partners. And with the high levels of gender-based violence in our region, this is a big concern and may prompt people to stop taking their pills. And then there are the social and structural factors, which are about cost and access to healthcare. And I think for me, what's been striking is that many of these factors that influence PrEP continuation also influence HIV risk, particularly in young people. So given these challenges, what evidence have we generated about what might support oral PrEP assistance? And this is just a summary of several studies that colleagues and I have been involved in Southern Africa, looking at different strategies that might support young women to take a pill a day. And I think what we've learned is that some things do work and some things don't. So we tried giving people feedback based on their concentrations of drug in their blood. But there were limitations of that approach, potentially because of the difficulties with not having a point of care test. We looked at whether empowerment clubs could support adherence. And although people really liked the clubs and it brought people together, it didn't have an impact on their ability to take a pill a day. There is some evidence that people may benefit initially from incentives or reimbursements, but that effect is not sustained. We've also looked at whether we can use mHealth strategies to provide adherence support, and both SMS and WhatsApp adherence clubs have been shown to be equally useful, although they haven't sort of made much change overall in terms of adherence. And also things like decision support tools that can perhaps take people through the decision to start oral PrEP in a way that they're more aware of kind of what it might entail in terms of daily pill taking. But I think the fundamental challenge is that many people struggle with taking a pill a day. And I think also if you're a young woman living in Eastern and Southern Africa, there are many social and structural barriers that may test your ability to stick with daily pill taking. So what we have been interested in is, can we develop PrEP modalities that may be longer acting? And as I mentioned, we have seen approvals for the vaginal ring and for an 8-weekly injectable PrEP. And there are a number of other studies to evaluate other agents, a monthly pill, a 6-monthly injection, and there is a real desire to increase the range of options that are available, because we recognize that oral pills are not feasible for everyone. And what we believe, based on what we know from the field of contraception, is that people are more likely to gain prevention benefits if we have a range of options that they can fit into their lifestyle at that particular stage of their life. So no single formulation is going to be workable for every person. And really what we need are a range of options that give people choice to use a method that is going to be most successful for them. So I just want to kind of conclude really by saying that we need a range of PrEP options that are going to fit into the lifestyles of women. And I think if we have that expanded choice, we really have an opportunity to change the trajectory of the HIV epidemic. There are some challenges to the first generation products. And, you know, as we prepare, I think, to see the vaginal ring and injectable PrEP introduced into demonstration projects and national programs, there are definitely things we're going to learn about PrEP delivery. But my hope is that newer and simpler agents will come. And really, you know, kind of what we need to recognize is that we need to mobilize broad partnerships with civil society and other groups to ensure that the barriers to treatment and prevention are addressed, and really that we get to grips with some of the underlying inequalities that are shaping both people's risk but also their access to prevention products. Because ultimately I believe that we can have these wonderful innovations, but if we don't have access, these are not innovations. Thank you very much for your attention.
Thank you, Prof. Sinead, and thank you to all the speakers. Now we can go and ask questions. I think I'm gonna start before I move to the questions in the chat. Please feel free to post your questions. I'll get to them later. So it's clear that from the presentation, the common message is that we need to understand the concerns of women, their challenges, in order to design better intervention strategies. I would like to ask Dr. Constance, how do healthcare providers in Zimbabwe and Zambia perceive the challenges that young women encounter in their lives and in accessing healthcare services? And how can they support or address these challenges?
Thank you, Ramla, for the question, and thank you very much to the other presenters. I think there was a nice rounded similarities and different perspectives. So in terms of healthcare providers, a lot of the healthcare providers, certainly in Zambia and Zimbabwe, are from the communities where their patients are coming from. And so I think they're very acutely aware of the risks that that these people are facing. And I think one of the ways that we've seen it being very successful is, again, I'll go back to Chiedza, which was this kind of integrated sexual and reproductive health service that was community-based. What the young people who attended that really appreciated was that the healthcare providers didn't just talk about HIV, they didn't just talk about STIs, they asked them about their families, they asked them about their lives, they asked them about the troubles that they were having in their relationships. So, and it some of that took time, but some of that could really just be a 1-sentence, 2-sentence acknowledgement that they were facing these other challenges in their lives. And I think that is something that's really valuable when we talk about, we talk about kind of youth-friendly care. But to me, so much of it is the healthcare providers' acknowledgement that their health issues come enmeshed with all these other challenges that they're facing in their lives.
All right. Thank you. I think that will go very well with my next question, which is, how do we can young women support women access to healthcare? And I think this can be answered by any of you, because you did mention that the responsibility of partners is quite important in the sexual health for women as well. Perhaps Prof. Mugo would like to say something about that.
I was thinking it through and then I got directed. Sorry, just phrase it again.
How do young men help women with access to healthcare? What would their role be in providing a safety net for women?
So thank you so much. I think it's important that we don't ignore the role that the community plays around young women and the importance they put to their male partners or the male community around them and the perceptions that they have about them, why she may have to hide her pills and what that perception is if you're taking pills. What does your partner think if you're taking PrEP? Are you unfaithful? Is he unfaithful? Do we have community buy-in? And those young men are such an important part of that community, especially at that very young age when the vulnerabilities are highest. So you're asking what role can they play? What can we do? Usually in the past that I've been very quick to say what I think we should do to include and educate young men. But actually I was just, chatting with Sinead that we assume on what would work. And then science shows us it doesn't always work. We thought that doing reminders on PrEP for young women would increase their adherence. It didn't work. And I think we need to put more effort in understanding the ways to work with the community, including young men around young women, that would enhance their use of products that have been shown by science to work. I hope I haven't gone off the bush, and I'd encourage comments from the others. Really value it.
Thank you, Prof. Mugo.
Maybe
I find it, yes, please go ahead, Prof. Sinead.
Well, maybe I can just build on sort of what the two previous speakers have said. But I think what we hear from young women that we work with is often they feel that they are the only ones responsible for HIV prevention. Here they are being kind of good citizens and taking PrEP, often when people around them don't know about PrEP, and they've had to be ambassadors for HIV prevention and to justify why they should take, kind of a pill a day and why they're not living with HIV. So, I really believe that we will not be able to address the challenges we face with HIV if we do not address kind of the underlying inequalities that are fundamentally driving why young women are at risk. And so kind of one of them is in fact the gender inequalities, which in its most extreme form manifests as violence, but kind of in simpler forms is just kind of the challenge that women experience every day to kind of have equal access to education, to knowledge, and I think that kind of that is the responsibility of everyone, and we as scientists at least can talk about how we kind of mobilize people and how we are more inclusive, so that people feel like this is a message that's not just for women. It is in fact for young men and parents who are worried about kind of what this means for their children. So I think it's also a challenge to us to think about how we communicate some of these ideas so that we don't put all of the responsibility on young women, and so that we kind of create conversations that do include young men, that help them to recognize their risk, that draw them into health services, kind of and ultimately more equal societies are beneficial for all of us. So, kind of while we may be scientists working in health, I think we're all of us on this call are citizens, and kind of those are the opportunities that present themselves to us.
Thank you, Prof. Sinead. So we all need to help each other and understand the needs around us to be able to help young women. Yes, Dr. Constance.
I just wanted to jump in and build on both of the two responses. But to me, I think the biggest support that men can do for women's health and women's, encouraging them to go to services is for men to go to services, for men to go to health services. And that's something that we see as a challenge again and again and again. And I know that a lot of people have done some really exciting, creative ways of trying to encourage men or young men to come to services. So we've tried offering boxer shorts or haircuts at health services, and that has had some impact. But I think next I'd like to go further and offer the particular need that young men face is sort of economic income generation. So what can we do to provide something around that links to health services and will support men to access health services? Thank you.
Okay, thank you. I would love to hear hopefully from the men, if some of them are here today, what they think about that. But before that, I would like to ask Prof. Sinead a question regarding how can PrEP be made affordable and accessible for young women in low and middle income countries? Because from what we talked about today, it's the financial constraint is quite clear in our areas.
Yeah, no, I mean, at the moment, it's one of the biggest questions and one of the biggest challenges that we will face kind of moving forward in HIV prevention if we really want to realize our ambition of kind of having choice. I think in South Africa, we're very fortunate in that our government has funded our HIV prevention program and has paid for oral PrEP. But kind of what we know about the discussions about adding other options is that it becomes kind of unaffordable to governments, even though it may be cost effective. Just kind of the bill is a is a big issue. Kind of, and I think what we're looking at are creative partnerships with donors across a range of agencies to understand how to overcome some of these challenges. I think ultimately what we need is generic manufacturing, but not just generic manufacturing in low and middle income countries. We actually need that on the African continent. And, kind of, I think what I have learned kind of from my time working in HIV prevention is that the sooner you start these discussions and the sooner you start designing products that can be used by people, but also can be made where people live, kind of that is when we begin to see true access. So, I think those are some of the conversations we're going to have to engage in the coming months and years ahead to make sure that we do not just have good ideas, but really have access to products that can protect people.
Thank you all for your valuable input. I'm just going to see if there are any questions from the chat.
As you do that, I really want to just put in bold what Sinead talked about local manufacturing, about having products that can be made where the people who need them. And maybe we shouldn't let go of that idea. And remember that, of course, we can do this. It's feasible. We don't need to be importers of everything. And once we make them, then they can be accessible easily.
Thank you for your comment, Prof. Mugo. There is a question in the chat for Constance. In terms of competing interests hampering HIV prevention, would this be a case of short-term priorities for these women versus long-term needs? Or that we need to get better at telling compelling stories to encourage uptake?
Thanks, Ramla. I think I answered it in the chat, but essentially, I think that is maybe part of it. I think, you know, all of us have challenges sort of seeing our long-term priorities, but I actually think a lot of the decisions that people make are including their long-term priorities. So, for example, the story that I gave of Rhoda, her goal was around college in order to get education, in order to get a job, in order to support her family. And that's a long-term goal. And so I don't think it's necessarily only that dichotomy. And then, so to me, I think making health services meet the needs that individuals see as their own priorities. And then once they're there, also introducing them to kind of what we see as public health priorities. Thank you.
Thank you. I hope that answers the question. The next question is, will it be interesting if the panel could give their thoughts on what the broader care service should look like and how it can be made economically viable? Should I repeat the question?
Yeah, no, I can give it a shot, and others I'm sure will add. I mean, I think what we're understanding about HIV treatment and prevention is really that we need demedicalized, decentralized services. And I think particularly for PrEP, where you're dealing with people who are essentially healthy, coming to a clinic every month is just kind of not really an attractive or feasible option for many people. So there has been a big move to think about how to decentralize, demedicalize, and take services to where people are. And then, you know, kind of, I think we need the appropriate technologies that really are going to respond to people's health, not just their HIV. And I think Constance and Nelly have both said this, but, you know, kind of that to deal with people's sexual health, you know, kind of you want to be protected from HIV, but that may still put you at risk for sexually transmitted infections. And I think what we know is that we have lagged behind in the development of interventions for sexually transmitted infections. So I think, you know, we need to focus on that, but then we need to make sure that whatever technologies we develop, those can be delivered to people in a sort of, in the places where they are, be that barbershops or hair salons or local community halls or on mobile vans. But, you know, kind of we need to think smart about the interventions that we do want to deliver to people so that they are taken up and they are accessible. And, you know, kind of some of that, as we said, comes with a funding envelope. So we're going to have to be very creative as we think about, you know, kind of how we develop new technologies, how we combine technologies. So, for example, multi-purpose prevention agents where you can prevent HIV, but also can prevent pregnancy in one product may be attractive, or, you know, vaccines that can prevent more than one sexually transmitted infection. So, you know, kind of those are the things we have to think about. But starting off, we should just think about how to make services accessible to people and respond to their sexual health needs, which are not just HIV needs.
Yes, I totally agree. We need to empower our women to be able to talk about how they perceive HIV risk in a safe environment. So the next question is also for you, Prof. Sinead. Studies have shown that STI testing at point of care tests can encourage adherence. What are your thoughts on demonstrating risk to women in order to encourage adherence?
Yeah, I think it's a really interesting idea. I think what we've seen is also that people who are highly adherent to PrEP often are at higher risk for STIs. And obviously they're motivated to take their oral PrEP every day and may not be using condoms, but they then are at risk for sexually transmitted infections. So I think that's why we have made a strong case for including testing for sexually transmitted infections as part of the PrEP package, because it's a way for people to identify their risk, but also if they are at risk for one sexually transmitted infection, which is HIV, they may be at risk or vulnerable to others. And it's important that we're able to identify those other infections so that we can treat them or offer interventions that may ultimately kind of prevent them. And this is, I think, just to kind of confirm this idea that we need an integrated package of sexual and reproductive health services for young women in particular.
Okay, thank you for your answer. And I think I'm going to ask one last question because it's almost 2:00. HIV prevention campaigns are really essential. One of our participant is wondering how we can promote these campaigns in communities with high gender-based violence.
I honestly have always felt, I mean, it comes back to what Sinead said. So young women carrying a highest burden of HIV infections, but they're getting, I think the data showed they often get it from older men, but we've been targeting them and we haven't had a community-wide advocacy focus. And I know that there's an issue of resources, but it's also clear that targeting the young woman alone is not working. So finding ways to use those resources for the community around the young woman in a way that impacts her. And I think also focusing from the sources of infection that come to her. I think this is true of South Africa and almost everywhere else. If you look at girls before the age of 18, I don't know what the data is need for South Africa, but the HIV prevalence in Kenya is pretty low. Then it just goes twap, between 18 and 20. So we have a window right there to do something before it all happens. And who to talk to it about perhaps is, and the target of our interventions, the focus of our communication needs to go beyond the young woman so that the ownership of protecting young women shouldn't be just on her. And the value of the young woman should be a community-wide. And I think that also comes back to the messaging, whether to frame a positive message, not just a risk message. The same way we say for PrEP, we need to talk about young girls, about protecting a future of being beautiful rather than just disease. Maybe we need to reach communities and talk about protecting young women. They are young women.
Thank you, Prof. Mugo. And with that, I would like to express my thanks to all of our speakers for their valuable input and significant contribution to this conversation. So the take-home message is that we need to understand and address these interconnected factors that are crucial for developing effective prevention strategies in order to reduce the burden of women, and especially that we know that women are at higher risk compared to their male counterparts. So I would like to also thank the participants, our audience, for joining us today. So there is a link to an evaluation form that is posted in the chat box. Please give us take some time to let us know your thoughts. And our next Women Up to No Good webinar is going to happen next year, probably around March or April. Please keep an eye on our new e-newsletter and social media for more information. Also, please remember to sign up for our e-newsletter and subscribe to the GIF Media channels. And for those who have missed any part of this webinar and wish to revisit it, there is a recording that will be uploaded to the GIF YouTube channel. Once again, thank you all for your participation, and we look forward to welcoming you to the next webinar. See you soon.
Thank you.